Welcome back, everyone, to another episode of This Week in Pulmonary and Critical Care Medicine. I'm your host, Aladdin Sagar, and I'm really glad you're here. Every week, we look at a few original research articles that matter at the bedside, studies that actually shift how you and I manage patients in the ICU, on the wards, and in the bronchoscopy suite. I'll also highlight one review article that's worth your time. Something that distills a complex topic into a practical, actionable format. As always, what you hear today is for education, not medical advice for any single patient. And if you want to explore these studies yourself, the links to all the articles are in the episode description. This week, we're covering a chest secondary analysis looking at oxygen saturation targets after cardiac arrest. And yes, this one gives us numbers that challenge our instincts. The AABIP's new evidence-based guideline on bronchoscopic diagnosis and mediastinal staging, the most unified approach we've had in years. A major JAMA trial, the top trial, comparing liberal versus restrictive transfusion thresholds in patients with high cardiac risk. And we'll close with a chest How I Do It review article on high-flow nasal cannula liberation, probably one of the most practical respiratory care pieces published this year. Let's get started. This first study comes from Chest, published in November 2025. It dives into a question that every intensivist faces within minutes of getting return of spontaneous circulation. How much oxygen is enough? And how much is too much for the post-arrest brain? We've all been taught that hypoxemia is harmful. That part is obvious. But the harms of hyperoxemia remain controversial. Observational studies have shown associations with worse neurologic outcomes, while randomized trials have been inconsistent. Some show signal toward harm, others show no difference, and a few early studies suggested potential benefit, so the field remains unsettled. This chest analysis, led by Damazi and colleagues, is a pre-planned secondary analysis of the large pilot trial. The parent pilot trial randomized nearly 3,000 mechanically ventilated ICU patients to lower between 88 to 92%, intermediate between 92 to 96%, or higher, between 96 to 100% oxygen saturation targets. The main trial found no difference in ventilator-free days or mortality, but here the authors zoomed into the subset of patients who had a cardiac arrest prior to enrollment, a group that's neurologically vulnerable, physiologically unstable, and underrepresented in prior oxygen target studies. Out of 2,987 total pilot participants, 339, or 11.3%, were post-cardiac arrest patients. Among them, 221 patients received a lower or intermediate SpO2 target, that's to say between 88 and 96%, and 118 patients received a higher target, between 96 and 100%. The key result is straightforward. 22.6% of patients in the lower intermediate group achieved survival with favorable neurologic outcome at discharge, compared with 12.7% in the high oxygen group. That's an absolute difference of 9.9 percentage points, with a 95% confidence interval from 1.8 to 18.1, and a p-value of 0.03. In plain terms, patients treated with lower or mid-range oxygen saturations had almost double the rate of good neurologic outcomes. Importantly, both groups were actually maintained very close together in practice. Median oxygen saturation was 95% in the low intermediate group versus 97% in the high group, so the physiologic separation was small. Yet despite these modest differences, the outcome divergence was meaningful. Mortality trended in the same direction, though not statistically significant. So what do we do with this? From a bedside standpoint, the practical message is that aggressive oxygenation in post-arrest patients may be unnecessary and potentially harmful, even if you're just nudging the saturation from 95% up to 99%. Maintaining patients in the 88 to 96% range, which is already consistent with most ICU targets, seems not only safe, but possibly beneficial. The editorial link to this article notes that the post-arrest field has been in flux ever since the TTM2 trial cast doubt on hypothermia. With hypothermia de-emphasized, there's growing interest in other modifiable targets, and oxygenation is one of the few levers we still have. But caution is warranted. This was a secondary analysis, and the authors themselves emphasize that these findings should be hypothesis-generating. A dedicated randomized trial in cardiac arrest survivors will be needed to confirm causality. In my opinion, the physiologic rationale is sound. Hyperoxemia drives oxidative injury and cerebral vasoconstriction at a time when the brain is already ischemia sensitive. Even modestly elevated oxygen saturation levels may matter early on. This study won't settle the debate, but it moves the needle toward targeting normoxia, not hyperoxia. So for now, letting your post-arrest patients sit at 92 to 95% is probably not undertreating them. It might be the safer choice. Next, we turn to the Journal of Bronchology and Interventional Pulmonology, which published one of the most anticipated documents of the year, the 2025 AABIP Evidence-Based Guidelines on Bronchoscopic Diagnosis of Peripheral Pulmonary Nodules and Convex Probe EBUS for Mediastinal Staging. These guidelines matter because lung cancer remains the leading cause of cancer-related mortality, and practice patterns vary enormously from center to center. Some institutions rely heavily on transthoracic needle biopsy, others on advanced bronchoscopy. Some perform systematic EBUS staging, while others still target only radiographically abnormal nodes. That variability produces unequal outcomes. These guidelines attempt to harmonize the field with a grade-based, methodical, and honestly, very pragmatic approach. The panel evaluated 9 PICO questions, informed by a systematic review through March 2023. 6 recommendations were supported by meta-analyses, 3 by systematic reviews. Importantly, recommendations follow NICE language: offer, use, consider, do not routinely offer, and so on, which is a clearer, more actionable vocabulary than traditional guideline phrasing. Let's walk through the major recommendations and the evidence behind them, focusing on what matters for clinicians. First, the guideline advises clinicians to consider peripheral navigational bronchoscopy rather than CT-guided transthoracic needle biopsy for indeterminate peripheral nodules. This recommendation is grounded in older meta-analysis data showing higher diagnostic yields with CT-guided transthoracic biopsy, but that data reflects a generation of bronchoscopy that no longer exists. Today's platforms, robotic bronchoscopy, cone beam CT, augmented fluoroscopy, precise rebus localization, have dramatically improved diagnostic performance. The panel explicitly notes that emerging contemporary data show comparable yields with lower pneumothorax rates, plus the advantage of simultaneous nodal staging. So the recommendation is cautious but forward-looking. Second, the guidelines recommend using multiple biopsy tools instead of a single tool during bronchoscopy for peripheral nodules. Across 10 studies, the meta-analysis shows increased diagnostic yield with no meaningful increase in complications. The effect size is moderate, not dramatic, but clinically relevant. For most operators, that means combining forceps biopsy with a needle or brushing, depending on lesion anatomy. Third, the guideline supports using ROSE when feasible. The meta-analysis shows ROSE improves diagnostic yield and facilitates triaging for molecular testing without prolonging procedure time. but the authors emphasize a realistic caveat. ROSE is resource dependent, and implementation must match cytopathology staffing and institutional workflow. Fourth, and notably, the panel makes no recommendation on whether bronchoscopy or CT-guided biopsy is superior for obtaining tissue for molecular testing. The meta-analysis of 3 comparative studies showed no significant difference. Both modalities produce high adequacy rates for molecular profiling. That's reassuring for clinicians who rely on airway-based sampling for medically complex patients. The next set of recommendations deals with convex probe EBIS mediastinal staging, an area where practice varies even more widely. The AABIP strongly recommends performing systematic mediastinal staging, meaning sampling N3 followed by N2, then N1 stations, even when imaging shows no abnormal nodes. Systematic staging identifies 5 to 15% more occult N2/N3 disease compared with sampling only radiographically abnormal nodes. This is one of the clearest take-home points. Targeted staging misses disease. Second, the guideline advises against routinely performing surgical mediastinoscopy after a negative EBUS, even in patients with risk factors for occult nodal metastasis. Meta-analysis shows mediastinoscopy adds very little yield and does not meaningfully reduce unexpected nodal disease at surgery. Next, tumor size more than 3 centimeters is highlighted as a major risk factor for occult mediastinal metastasis, roughly doubling the likelihood of N2 and N3 disease. Here, the panel does not issue a direct use-do not use recommendation, but urges clinicians to integrate tumor size into their staging strategy. Finally, the panel recommends not performing invasive staging for pure ground glass nodules, which have extremely low rates of nodal disease. From a critical perspective, these guidelines finally bring structure to a field that has outpaced its own evidence. Bronchoscopic technology has evolved faster than trial data, and the panel does a good job balancing older evidence with contemporary clinical reality. The emphasis on systematic EBUS staging is especially valuable. It's the single most practice-changing element for many centers. The guidelines aren't perfect. Evidence quality varies, and many recommendations rely on consensus. But this is the clearest, most unified bronchoscopic diagnostic pathway we've had in years. Our third article comes from JAMA, and it addresses a question that surgeons, hospitalists, and intensivists argue about endlessly. What hemoglobin threshold should we use when transfusing patients with high cardiac risk after major surgery? For years, most guidelines recommended a restrictive transfusion strategy. Transfuse when the hemoglobin drops below 7 grams per deciliter. It's simple, it's resource conserving, and in most populations, it's been proven safe. But there has always been a lingering concern that patients with ischemic heart disease, peripheral arterial disease, or prior stroke may not tolerate the oxygen-carrying deficit of a hemoglobin of 7, especially in the immediate postoperative period when demand is high and physiology is unstable. The TOP trial, Transfusion Trigger After Operations in High Cardiac Risk Patients, was designed to answer exactly this. It is one of the largest, most rigorous trials to look specifically at postoperative patients with high baseline cardiovascular risk. The investigators enrolled 1,428 veterans across 16 VA medical centers. Nearly all were men with a mean age of about 70. Over 90% underwent major vascular surgery, procedures known for high blood loss and high postoperative cardiac complications. To be included, patients had to have a history of ischemic heart disease, MI, peripheral arterial disease, stroke, or TIA. Patients were randomized if their postoperative hemoglobin fell below 10 grams per deciliter. The liberal strategy transfused at less than 10 grams per deciliter. The restrictive strategy transfused at less than 7 grams per deciliter. This is a huge separation, much larger than most prior trials. By day 5, the hemoglobin levels differed by about 2 grams per deciliter, showing that the protocol worked. The primary outcome was a composite of all-cause mortality, MI, coronary revascularization, stroke, or acute kidney failure within 90 days. The results? The primary outcome occurred in 9.1% of patients in the liberal strategy versus 10.1% in the restrictive strategy, a relative risk of 0.90 with a 95% confidence interval of 0.65 to 1.24. That confidence interval crosses 1, meaning no significant difference. On the surface, restrictive transfusion again appears safe, but the nuance lies in the secondary outcomes. One pre-specified secondary endpoint, cardiac complications other than MI, actually favored the liberal strategy. These events occurred in 5.9% of liberal strategy patients versus 9.9% of restrictive strategy patients. That corresponds to a relative risk of 0.59 and the 99% confidence interval of 0.36 to 0.98 does not cross 1. This is meaningful. Breaking it down, new arrhythmias requiring treatment, 2.6% versus 4.3%. New or worsening heart failure, 4.0% versus 5.8%. This pattern suggests that prolonged anemia may worsen myocardial oxygen mismatch, potentially precipitating arrhythmias and heart failure, an idea that aligns with pathophysiologic intuition. But there are caveats. Event rates were lower than expected, meaning the study may be underpowered. The authors estimate that more than 36,000 patients would be needed to detect a small but clinically meaningful effect with adequate power, essentially impossible. Also, the cohort was almost entirely male, limiting generalizability. The accompanying editorial makes a key point. Most trials in cardiac patients show a similar pattern. The primary outcome is neutral, but point estimates consistently favor a more liberal strategy. We haven't yet proven that restrictive transfusion is harmful in cardiac patients, but the accumulated data suggest that the one-size-fits-all threshold of 7 grams per deciliter might not be ideal for everyone. So what does that mean? For the average postoperative patient, restrictive transfusion is appropriate. But for the patient with significant ischemic disease, new postoperative tachyarrhythmia, borderline hemodynamics, or evidence of myocardial oxygen supply-demand mismatch, this trial gives you permission and maybe a reason to transfuse earlier. So while the top trial doesn't overturn the restrictive strategy, it adds nuance. In high-risk cardiac patients, a hemoglobin of 7 grams per deciliter may be safe statistically, but not necessarily optimal physiologically. We'll close today with a chest review article that's extremely practical. It focuses on a topic that every ICU physician, fellow, and respiratory therapist struggles with. When do we liberate a patient from high-flow nasal cannula, and how do we do it safely? High-flow nasal cannula has become one of the dominant, non-invasive respiratory support modalities in acute hypoxemic respiratory failure. It improves oxygenation by matching inspiratory demand, washing out dead space, lowering the metabolic cost of breathing, and providing modest positive pressure. And since COVID, high-flow nasal cannula use has exploded, not only in ICUs, but in step-down units and EDs. But while we've become great at starting high-flow nasal cannula, we're far less systematic about stopping it. Many patients linger on high-flow nasal cannula longer than necessary due to inconsistent practices, lack of protocols, or fear of failure. The authors note that current high-flow nasal cannula discontinuation patterns are highly variable, often dependent on the comfort level of whoever is at the bedside. And that variability leads to consequences. prolonged ICU stay, increased hospital costs, and inefficient use of limited resources. So this review proposes a standardized, physiology-driven approach to HFNC weaning, modeled after spontaneous breathing trials for ventilator liberation. To guide their protocol, the authors walk through high-flow nasal cannula's physiologic effects, most notably, reduction of anatomic dead space through flow-dependent washout of CO2 in the upper airway. This directly reduces the work of breathing. Second, reliable delivery of high FiO2, since high-flow nasal cannula can match or exceed inspiratory flow rates. Third, humidification and warming of inspired gas, improving mucociliary function and respiratory comfort. And last but not least, generation of low-level positive airway pressure, assisting alveolar recruitment. Understanding these principles helps determine who is ready to wean, because high-flow nasal cannula is doing multiple things for these patients, not just oxygenation. The review proposes a structured liberation trial using the following readiness criteria: FiO2 equal or less than 50%, flow equal or less than 40 liters per minute, saturation equal or more than 92%, respiratory rate near baseline for patient, minimal or no accessory muscle use, clinical stability in terms of hemodynamics, mental status, and secretions. If the patient meets these thresholds, the authors recommend a stepwise trial rather than gradual tapering throughout the day. Specifically, they suggest to reduce flow to 20 to 25 liters per minute while keeping FiO2 constant. Then, observe for 10 to 15 minutes, mainly respiratory rate, work of breathing, accessory muscle use, dyspnea, and saturation. If tolerated, transition directly to conventional oxygen, 2 to 6 liters per minute. Then, reassess within 30 minutes. If the trial fails, for example, increased work of breathing, desaturation, tachypnea, resume the previous high-flow nasal cannula settings and try again later. This approach mirrors the logic of ventilator SBTs. The goal is not to slowly taper support indefinitely, but to identify whether the patient can sustain adequate gas exchange and comfortable breathing with a decisive test. Interestingly, the authors point out that high-flow nasal cannula is often left running at high flows even when the patient no longer requires the dead space washout effect. That means many patients could be weaned sooner than we think. This review fills a long-standing gap. We have strong evidence for high-flow nasal cannula initiation, but almost no randomized data on discontinuation strategies. The author's protocol is grounded in physiology and real-world practice, and it gives clinicians a shared mental model. Until trials emerge comparing specific weaning approaches, this structured high-flow nasal cannula liberation method is the most rational way to standardize care, decrease ICU length of stay, and reduce unnecessary resource use. If your unit doesn't have a formal high-flow nasal cannula weaning protocol, and most don't, this article is worth circulating at your next respiratory care meeting. So that's our roundup for this week. From oxygen targets after cardiac arrest, to the new AABIP diagnostic and staging guidelines, to the top trial on transfusion thresholds, and finally, the high-flow nasal cannula liberation framework that's long overdue. Each of these studies adds a small piece to the bigger picture of how we take care of critically ill patients, and together, they nudge us toward sharper, more thoughtful practice. If you want updates like this every week, clear, concise, clinically relevant, make sure to subscribe so you don't miss the next episode. And if you know someone who'd benefit from quick, high-yield summaries without having to dig through every journal issue, share this episode with them. It helps the channel grow and it keeps the weekly series sustainable. All the articles we discussed are linked in the description. I'll be back next week with new trials, new insights, and another review article that's worth your time. Thanks for tuning in. and I'll see you in the next episode of This Week in Pulmonary and Critical Care Medicine.